Okay, come on, guys, only 10 seconds. Okay, so select the best answer. What is your number one challenge in this class? Number one, lack of time. And remember, this is only on 34 of you guys. So I don't know about the 68, no, 64. Yeah, 66 other students. But hopefully that give me an answer. What is the issue here? And you, number one, there's no time to study this course. Number two, you do not understand the instructor. Number three, you do not understand the material. And number four, the class is too boring to discuss with other students. And then number five is other reasons. So I'd like you to tell me, this is really open discussion today. We'll talk about surgery, but I really want to spend much time with you guys today, try to dig into the issue and try to solve the problem here. Okay. Any comments? Raise your hand, talk to me. All right, fabulous. So 53% of you don't have time going to the class. This is not surprise, right? So this will be an issue whenever you go or whatever you do, because we don't always have time, right? So I don't know. Let me ask you this. Have you ever, as a student, resident, or attending doctor, have you ever learned a time management course in Vietnam? How to manage your time? Have you done that in Vietnam? Or this is the first time you heard it? Okay. So let me share with you one secret thing. Okay, a lot of people ask me all the time, Dr. Wynn, how come you do a lot of things and you feel full of energy? Like after 6 p.m. you do a lot of things and then you go to running, you do all kind of crazy. Let me tell you one thing that I think I can do okay compared to other people. I manage my time. And this is the crucial thing that I want to tell you. As a doctor, you should know how to manage your time. Because if you don't, you cannot do anything. You will continue to struggle with your life. You will constantly struggle with your life, with job, with family, with whatever out there, because life very, very hectic. And as physician, we always have a lot of problems with hospital, with patient, with all kind of things. So I don't know if you interest enough, I can spend 45 minutes to talk about time management for you guys. And this is a special section for you guys. I did a couple of time management class back in Vietnam, and most of my students, they love it. And I will tell you, the student here in the US, they love this class because this is very simple, but also help you prioritize your task, help you focus on your goal. Because one thing I will tell you right now, if you're telling me you don't have time for this class, telling me that you have an issue with managing your time, because this is a commitment from both sides, from us and from you guys. If you don't have time to go to this class, it is very difficult for us to focus on teaching. All right. All right. Now I want you guys to talk to me, and this is another issue. Raise your hand. I want to hear some voice. I don't want to hear a mono dialogue. I don't want that. So talk to me. Okay. Let's say Nga, go ahead.
Okay, so in Vietnam, I haven't enjoyed any time management class. So I really like to hear from you how to manage our times. As a doctor, we both very busy. We have a lot of tasks to do in our life. So please share with us.
Okay, sure. Well, one thing, yeah, I love your comments, and let me tell you one thing. First of all, don't ever think you guys are busy. That's mentality. I want you to think about change your mindset. First of all, I don't want my students say two words. Number one, I don't have time. This is a very bad excuse. If you're telling me you don't have time, it is such an excuse, because everyone have 24 hours, no matter what. You, me, and Dean, whoever out there, 24 hours. It is our job to utilize those hours. And if you ever follow my graphics in the time management class, you realize that a lot of time we do actually wasting. We got non-productive timing, and we spend so much time in non-productive. And in that lecture, I will show you what are the signs or symptoms of non-productive timing, and you need to go away from that, because your time, let me tell you a very 2 minutes about time management. Your time is money. Okay, if no one here care about time, I'm telling you right now, your time is money. And you know how much money you're making right now? Anyone guess what is your
No,
time?
I don't know.
Now you do know, right?
Yeah,
So I'm telling every doctor in the US here, relatively speaking, if we talk today, every hour you guys spending whatever, you make almost $80. Like even you sleep, that's a doctor, and you have to make like every second, every hour, no matter what you do, you go restroom, you sleep, that's $80. Like you make $1.25, almost 25 cents every 1 minute. So think about it. And this is simple. Why? Because sometimes you want to save gas, right? Think about it. Okay, one of my friends want to go to that station to fill gas to save $2 total. And I asked her, how long does it take you to go and back? Oh, about half an hour. So I'm telling you, you must use $60 to save $2. And she say, how? I mean, I don't get it. Why waste? Because I'm telling you right now, with your salary, I divide by a number out per year, you make about $80 per hour. And now with that, you make $1 some per minute. If you drive from here there and try to save by gas, you're losing $58. So just tell you one something. If you ever don't want to think about it, but it's time money, let's give one example that you should think about it. And every second, every choice you make in this life is about your time. And let me ask you one more question. You know how many minutes you have left in this life? You don't ever think about it, right? How many years you have left in this life? And let me tell you how many minutes, how many heartbeats you may have left in this life. Is anyone guess how many minutes you will or you have left? You don't know, right? But think kind of scary, right? So this, I give you those concepts to think about it, because our heart can beat almost 2.5 billion times in our life. And the lung can do about 800 to 700 million breaths. So if you are about this age, you consume about 1/3 of your life. So your heart can beat about 1.5 billion more before it stops. And I'm talking to you right now, my heart just beat like a few of them. So those concepts, I want you to think about it. Like time is relative. We don't have a lot of time, and time is money. So those two concepts, I want you to go home and think about it. Like you have not many time left in this life. So every moment you decide, every second you want to spend, you really want to make the most out of that. Whatever is your goal in life, you want to become this and this, but this is what you really focus on your time. So understand what your timing will make you a better planner. All right, with that in mind, let's go into this today class. And I hope this will be a fun class, because I don't know if you guys know this, I wanted to become a neurosurgeon when I was medical school. And my training in the first several years in medical school focusing on that. So I sleep in the OR. I spent a lot of time in the OR, and I will tell you, if you read my books, you will know why I changed in the last minutes. So this is one thing that I always miss the OR, miss the time, and miss my people there. So hopefully I can share with you in this lecture, and then we'll go from there. All right. Can anyone see my slide at the moment? Good?
Yeah.
All right.
Yes, very clearly.
Good. All right. So the goal of this lecture is I'd like you to know about the training of surgeon, how to become a surgeon in the US, general surgeon versus specialist surgeon, and then anesthesiologist. This is the term I want you to able to spell, anesthesiologist, okay? And this is actually, and Dean, he used to be, or I don't know if you remember, this is Dr. Dean specialty. And then learn about surgical treatment phases, because we have multiple phases in surgical care. And I want you to get familiarized with each phase, because in each phase, there are challenges, but also issues that you need to resolve in order to provide a better patient care. I'd like to share and want you to learn about the basic term in surgery, include surfaces, like how to apply those terms in daily communication. And lastly, I want you to tell about complication with patient, because this is the number one issue that you have to deal as a surgeon. So think about that. You think that you operate someone, you make someone happy, but not yet. 1 in every 10 patients may have complication. 1 out of 10, very common, extremely common. So as a surgeon, or you want to talk a surgical language, you must know the complication. All right, so here's the outline, and I will spend some time to talk about surgical PA, OR nurse, surgical tech, and then we'll talk about the main 4 phases: pre-operative care, evaluation and management, peri-operative care. This is in the hospital, but not yet in the OR. And then intra-operative, this is in the OR. And then post-op after the OR. And then lastly, complication. And then we did some, hand out some surgical basic terminology to you guys already. All right, I will check my chats intermittently. And then hopefully, okay, let me do this. How many of you ever in the OR? Raise your hand for me. Okay, well, come on, guys. I expect all of you, right? Or at least some of you. Okay, have you ever been in the OR? Yes or no? In whatever role? Yes or no? Okay, let me see. Okay. All right, so share with me. Someone raise your hand. In what role? Okay, if you're a patient, it's okay too. Were you a patient in the OR? That's fine. But tell me, what role in the OR? Okay, let me go with Yung. First, number 40. Go ahead, Yung.
Hello, Dr. Wynn. Hello, can you hear me?
Yeah.
Sorry, because it is noisy.
Oh, Yung, may I ask you to talk later because you have some background. So I will ask someone else, and I come back.
Okay. Can you hear me? Sorry,
Yeah.
Dr. Wynn.
Okay.
I have been as operating room, and I'm a neonate. I care newborn when a new baby was born, and yeah.
Okay, so let me get back to you. And number 90, Newman.
Good morning, Dr. Wynn and everyone. I am an obstetrician doctor.
Oh, perfect. Yes.
Yes, every day I come to the OR to
Okay.
have a C-section and take the baby out.
Okay.
Yes.
All right. Thank you for sharing that story. Okay. Who else? I want to hear more voices, guys. Come on. This is a fun class. Let's.
Hello,
okay.
doctor. Hello, teacher.
Yes.
I have two sections. Two sections, and I work to doctor, and I must to have. I spend 2 sections.
Okay. No, tell me, are you a doctor? Are you a nurse? What is your role in the OR?
I'm a doctor, neurologist.
Okay, neurologist.
Yes.
Okay, really cool. All right, neurologist. So what are you doing in the OR?
When I have pregnancy, 12 years around, and my baby was must to be C-section.
Okay.
Yes.
All right. So you were a patient, okay, but you are a
Yes,
neurologist.
I'm a patient. Yes.
Okay. Okay, good. Okay, let's go. Who else? Come on, guys. I like to hear more from you. Okay, this is like a fun interaction. Let's see.
Hello,
Nha Đỗ.
Dr. Wynn.
Okay, yes.
Yeah.
Thanks.
My name is Yi Phương.
Vâng.
Can you
Go
hear
ahead.
me?
Yes.
Yeah. When I was a medical student, sometimes I'm in OR as an observant. I just see what happened in the OR, and sometimes I work at a surgeon assistant. I just give the tool to the surgeon and I use to I serve as to blood. I will remove the blood so the surgeon can see the field clearly. Yeah, it's my role as when I a medical student.
Okay, cool. And last one, and before we move on here. Okay, Nga, go ahead. What was your role?
So as you guys may know that I'm an anesthesiologist.
Okay.
So I work as a doctor there. I go to the OR. I make my patient feel calm, undergoing surgery without pain. And also, one time last year, I take my mother go to the surgery. So I may be the family of the patient.
Oh, thank you. Now we have a surgeon. We have an obstetrician surgeon here, an obstetrician, and also an anesthesiologist. So do we have any general surgeon here? Anyone doing surgery every day? Raise your hand. You know what? I am very impressed. We have a general surgeon attend this class at the moment, because most of the time, you know, that they're telling me they're very busy. They always busy in the OR, and that's true. So we don't have any general surgeon here. We have a gynecologist, we have an obstetrician, we have an anesthesiologist here. And then, okay, so let's go back to this. I'll walk you through this, and then we come back with more fun class. Okay, so let's see where we are at. Let's share and we continue. All right. So you saw this again, but I want to show you it. Basically, it takes a lot of time to become a surgeon, and it takes a few more years. So the longest residency in the US for surgical field is neurosurgery. It's 7 years. All right, and not yet. When you finish neurosurgery, you may want to do 1 or 2 year fellowship. So end up 9 years. So one time I was a fellow at USC, and when I say a note, my note is PGY 7. That means I'm graduate year 7. It's kind of really long, right? And I saw a guy PGY 9. I said, what the heck? That means this guy graduated, like he did residency, fellowship, whatever, and now PGY 9. It means really, really long and old. It means you are such a long time resident or fellow. Now, whenever you think about surgical field, you realize that this is one of the most challenging and difficult because the time commitment. And I would not underestimate kind of undertaking this to you guys, because I will tell you this is very true in the US. I'm sure it's also true in Vietnam. So personally, I do have a lot of respect to surgeons out there. So if you guys ever see one, and if they're in this class, I really want to say hi to them. All right, so this is the timing, and the longest one usually surgical oncologist or CT cardiothoracic surgeon. And then if you want to subspecialize in surgery, you do 5-year residency already. You do fellowship, usually 1 or 2 years, or even 3 years. And they are plastic surgery, they do hand surgery, they do minimum invasive surgery. They have all kinds of surgery that you do 1 or 2 more year fellowship. The bottom line, it takes so long to become a surgeon, and I will not, again, undertake or counting those years, because it will be a lot of time for you guys. And then anesthesiologists, on the other hand, they also went to a lot of training. In the US, they are 4-year residency to become a general anesthesiologist. But after that, they can do 1 or 2 more years to become subspecialized. The most common one they do a pain doctor. So think about it. Anesthesiologist, they make patient don't feel. Basically, they put patient in sleep, right? So they are pretty good in terms of pain management. So that's what they do. All right, so this is the map that I want you to kind of give an idea and recall your time. Back in the day, I don't know what your position is, but I will tell you as students, you are nowhere in this level. So this is the chief surgeon. He stands in the middle, and this is the patient head rate, usually on the right side of the patient. And then this is the anesthesiologist with a monitor behind him. And then the assistant surgeon, usually the resident. The resident here, usually a surgical resident, 2nd year, 3rd year, 4th year. The intern are the one even behind him. I don't know if you see my cursor, but the intern is right here. And then circulating nurse is the one right here. And the most evil, I mean, most student or fellow or resident, they hate, or I don't say hate, they scare, is this gentleman or this scrub nurse, because she will yell at you, hey, wash your hand, because you somehow too excited, right? You want to reach out and see, oh, what is that? And then suddenly your hand and your hair touch that sterile field, and then you contaminate the entire OR. I have one case when I was a student. I told you I spent a lot of time in OR, right? And then not me, but one of my colleagues, she also a student, and she extremely excited, and she reached over, and then her hair touched the draft, and we have to change the entire draft. And I mean, she would yell so bad. I mean, she cried. I mean, this is like, oh my gosh. And I still remember that. It's very bad. So a student or intern, you go to the OR, you absolutely stay in your position, no matter what. If this is extremely cold, you've never seen in your life, stay calm and ask. Don't try to reach over and try to see, hey, can I see it? And then you may end up destroy entire team. All right, so this is another map that I usually told my residents. This is when you go to the OR, make sure you know who the chief surgeon is, but also know who is the anesthesiologist, because those two are the men that have pilot versus co-pilot to control the room. If you don't want to.
Sorry, teacher, can you speak slower? Teacher, can you speak slower? Yes.
Okay, sure. I can speak slower. The reason why, because we are running out of time. All right. So when you go to the OR, this is the map that I show my students. You should know who are the chief surgeon is and who are the anesthesiologist is, because those two are the main people in the OR. Okay. And then you should know who are the person that you follow, the resident, the fellow, and then you should know the nurse. So those are the people that, and in the bottom here, it's medical student, say minimum 500 feet. I found this cartoon, it's so funny, and I remember those years. So it is very true. As a medical student, you on the bottom, you have your role is on the bottom, not only the bottom, but pretty useless. I remember as a student, you don't have any role in the OR except learning, except observing. So, but this is also a very, very cool experience that every medical student should do it. And I believe you guys have to do at least 6 or 8 weeks of surgery in Vietnam, right? In the US, you have to do at least 8 weeks of surgical rotation, 2 rotation here. Most students do 3 months of surgery. All right. So what's the role of circulating nurse in OR? That's exactly what she does, and I will tell you in a second when we go to that slide. All right. So whenever you see an airplane, do you know why there's always 2 pilots, one captain, the other co-captains? And this is the reason why. In the OR, we need 2 captains because they watch each other. I used to, or at least the way that I would train is, one is more superior than other. Usually the surgeon role is more captain, the other one co-captain. But lately, what we found, the two of them, they complement each other. They need each other. So I want you to understand this role, this dynamic in the OR, the surgeon and the anesthesiologist, they complementary each other. Their role complete each other. Okay, they don't compete, but they make sure that each of them oversee each other to make sure a safe patient care during, before, and after the operation. However, the surgeon ultimately responsible for patient care legally. But I will tell you what, whenever they sue, they will sue both. I never left out anyone. So if you sue the surgeons, you will likely sue the anesthesiologists and vice versa. The two of them have a direct and crucial communication between, especially during operation. For example, when the surgeon asks the anesthesiologist, are we ready? Is this patient asleep or not? Like in this cartoon, can I take incision? And then they say, well, it is 29 years old. Is she fully under anesthesia? And then if the anesthesiologist said, well, no, not yet, then you have to wait. You don't cut that because the patient is not fully anesthesia yet. So in this cartoon, the patient may wake up and say, no, I'm only 28. Right? And so that's give you an idea that you have to wait and you have to communicate directly with each other. Because if you, for some reason, in the OR or while in the operation, patient blood pressure drop, and you need to know, otherwise you keep cutting and then guess what? The patient drop their pressure and you don't even feel it. So that's extremely dangerous. So those two are, they complementary or they complete each other. All right. I want you to learn this concept because some of you may learn that, oh, I'm a surgeon, I'm the king of this room. No. Okay, that's a very wrong concept. Or, well, I'm the anesthesiologist, everyone depend on me. That's also wrong. We are a team. Okay, so we are a team and we help each other. All right. Now, in the surgical OR, we also see PA, a physician assistant, or NP, a nurse practitioner. So those usually they finish one more year of residency in order to assist surgeon to operate. And you will see this a lot in the US, and they can work all phases of surgery. But the most common one is they do an perioperative. That means they help the surgeon assess the patient before the procedure. And then they can follow up in the hospital. For example, if today we do an appendectomy, and then usually the NP or PA can follow a patient in the hospital, make sure she's doing okay. In the OR, PA or NP can be the first or the second assistant to the chief surgeon. All right, now we talk about surgical and circulating nerve, right? This is one of the main RN OR. They oversee safety and procedure. They help the coordinate care with nursing, post-op nursing care, and they coordinate care with all the physicians, surgeon outside the OR, between OR. So this is a very, very crucial. Think about if you are a surgeon and you are an anesthesiologist, you are on an island, an isolated island. You cannot go in and out. You have to stay within your room. And the only way you can connect with the outside world is this nerve. You will tell, hey, can you go to the next room and get a cat for me or get this, because you need equipment. And guess what? Everyone in gown already. So you cannot go. So she is the one that go around, but also oversee, make sure that the timeout procedure was correct. Make sure that we do a timeout before we cut the patient. So those are the things that's extremely, very, very important. And as I say, this is the person that usually medical student or resident, they get yelled at because most of the time they do something that not appropriate, not clean, or they do things that they should not do. All right, one thing about CRNA, I don't know if you heard about this term, but this is very common in the US now. So CRNA stands for Certified Registered Nurse Anesthetic. CRNA are a higher level of RN, but they can administer, they can do intubation, they can intubate people, and they can help with surgeon. So they, in many states, they collaborate with the anesthesiologist, and they take care of, they induct, they can intubate, they put patient in sleep. In some states, however, CRNA can work independently, and they work directly with the surgeon to provide anesthetic care. Now, many CRNA nowadays, they have a doctor degree. They call it DNP, Doctor of Nurse Practitioner. I mentioned this earlier in other lecture. All right, the next one is a surgical tech. So this is the person that if you spend a lot of time in OR, perhaps you should be friendly with her, because I will tell you, she can change your world. Oh, I'd like to welcome Dr. Min, though. I just saw his name. Hello, Dr. Min. All right, so keep going. Now, to become a surgical tech in the US, you have to go to school and you have to take a national examination, and then you can work in the OR. So what is your job as a tech? You help transfer patient to and from the OR, you set up procedure. Now, here's the thing. Give me 1 second. All right, can anyone hear me? My internet was a little bit unstable. Is that okay now?
Yeah, it's okay.
Okay, good. All right. So let's continue. All right, surgical tech is the one that handling the equipment, instrument to the surgeon. And here's the thing, it's funny that I remember when you're in an OR, you should know this person, because if you sit in a wrong position, she will kick you out. The reason is she needs to be in proximal with the surgeon, right? She needs to be close to the surgeon. But at the same time, you want to sit next or standing next to the surgeon too, because you want to see, you want to learn, right? So you don't ever want to be in between her or him and the surgeon, because she will handle all type of equipment, like mail, whatever she needs, and then she give to the surgeon. So make sure that you know this person well, and this surgical tech, as I said, could be a really good teacher, because she will teach you all the instrument, and it's amazing. I will tell you, amazing how many instruments she know. One time she told me that one of the surgical techs, she remember over 1,000. Can you remember 1,000 instruments? That's what she remember. So that's just amazing how she know about those equipment, those instruments, and she know exactly the number, and she know exactly each surgeon habit, like what surgeon use what tool. It's just an amazing. I think this is the one thing that I remember her as one of my first teacher. All right, now we're moving to the treatment phases here. Whenever we talk about phase in surgical, we have to understand that in any phase like this, miscommunication can happen. And this is not why in this class, you guys try to talk to your patient, to your colleagues at any phase, try to make sure that clear communication are given to the surgeon and vice versa. So pre-operative care is when before the procedure, when we just started, peri around the procedure, and then intra during the procedure, and then post off is after the procedure. All right, let me go this quickly, and then we do some in-class exercise. First of all, the pre-operative care start with usually family doctor, internist, or other physician. For example, they found a mass in the neck, or they during this procedure or the CT, the patient have abdominal pain. Now the internist or the family doctor send this to the surgeon for evaluation. So that your role as a surgeon now, you evaluate for surgical treatment and then anesthesia. Remember, you have to evaluate two things at the same time. First of all, can you operate on this patient? And secondly, if you do, what type of anesthesia? And we will talk that in the next few slides. But the two outcomes usually is conservative treatment, like you just watch. You say, hey, you know what, that gallbladder, it's okay. There are stones in that, but we do not need to cut it out. I think it's safer, just watch. So that's conservative treatment. Now, you have to understand that not all consult or surgical consult end up in surgical procedure. A lot of time, they just want to make sure there is no need for surgery. Okay, that's one of the key things about surgeon, which I learned. Remember those days, my mentor said, one of the biggest job for surgeon is to not operate and to tell people not to operate, because that's not appropriate. Now, if intervention is needed, then you have to assess the risk. You assess the outcome benefit. Like, what if you cut this out? What is the benefit to the patient? And then the risk or complication, what could be the risk to my patient? And then you have to base on patient profile, medical history, nutritional status. This is extremely important. You cannot operate on someone malnutrition severely. You know this, right? Because if someone have severe problem with nutrition, they cannot heal well, and their wound care would be a nightmare to everyone. And then surgical history also important. Now, informed consent also important for you to talk to a patient at this phase, like even before the procedure. Now, we're moving to perioperative care. That means the patient now sounds like the patient needs a procedure and they agree, they are about to sign the informed consent. And now we have a day, we set up the patient in the hospital. And usually the patient come a few hours prior to the procedure and they NPO midnight, they don't eat anything. They basically just wait for you to cut them in the morning. And then they come to the hospital. And this is when you come, you assess the patient again. And this is also crucial because this is the final decision. If the patient says, hey, I don't want to have this surgery, then you have to stop the surgery, okay? And if the patient say, hey, you know what, it's too risky, or at that time, you realize the patient have some cardiac risk, they have a potential like a posterior or inferior MI on the EKG, and you say, wait a second, this is not good. You have to do this, maybe a different time. So this is the time that you have to reassess the patient. All right, keep moving on. We call type of anesthesia. So there are 4 types of anesthesia. You control the patient feeling of pain and respond. And the biggest one is everyone knows general anesthesia. So general anesthesia are the one that make patient completely sleep, and hopefully they don't feel anything, they don't hear anything. And this is one of the most reasons why people get sued, because guess what? I'm still awake during anesthesia. And this is why it's so, like, people make movie out of that, and they say, wow, you know what, you guys cut my gut open and I still see it, all kind of things that they can sue you. The other one is we call regional anesthesia. So for people, for example, they have C-section or they have knee surgery, they just want to block that. And then the other one, sedation. So sedation usually they do outpatient, they don't do in the hospital. Sometimes they do, but now they move to outpatient, we call surgical center. And lastly, local anesthesia. So local anesthesia is the one that many of you do, right? We suture the skin, we do biopsy, this is when we do local. Now, I have to tell you this, complication and mortality rate in surgery is happening. All right, so I give you this study, to observational study of trend in the US from 2012 to 2018. And guess what? The overall surgical complication happened 1 out of 10. So it's quite common. And what are they? They pain not control, they have infection, they have all kinds of things that could be potentially can improve or increase the risk of dying. And even with the better technology, the overall risk of dying in surgery is still there, perhaps in 1 to 2% if you calculate all the factors. So if you think about that, it's a major risk. So you have to talk to your patient. You have to tell the patient everything about this procedure, include the risk of dying, like that during and after the procedure, or even a few years from today, they can die because complication in the procedure early. All right. So this is about, we move into the second phase of the exercise we call surgical surfaces. So those are the terms that you may hear a lot, and I want you to know this term, and we're going to do some exercise with everyone, make sure that everyone at least try one with me, okay? Now, you can screenshot my share screen. You know how to do that. I'll just take a picture of that, because I want you to create a statement using a procedure that your imagination is. For example, we have tomy, we have ectomy, we have tone, we have scopy, we have scope, we have synthesis, and then we have pexy, we have plastic, we have gypsy, we have ataxia, we have algia, we have dynia, we have ectasis, and we have edema. All right, so this is the exercise. We are going to create a sentence using a surgical surface with the term that you can use those terms, and then you create one using your own one, okay? For example, we are going to perform an appendectomy. You can go slow, appendectomy, okay? So those are the surgical term that you can use here. So appendectomy, to cut the appendix, okay? So let me stop right here and go around and see who else. Well, first of all, any questions so far? Am I going too fast at the moment? Oh, no. Good. All right. So let me pick some number that I want you guys to exercise, and I want you to tap, okay? Tap. If you cannot participate, tap down your answer and using those term I just give you. Okay, so let me share with you again, and now let me copy and paste it to the chat box. All right, here we go. One, and then another one is here, and I want you to create an example for me. Okay, and then I will call someone to help me. All right, let's see who like to talk. Who like to? I haven't heard anyone today. Okay, number 90. Where is 90? Okay, 90. All right. Okay, go ahead, 90.
We are going to perform an hysterectomy.
All right, hysterectomy. So, okay, I'm a patient. So, Dr. Madam, what is hysterectomy?
Hysterectomy is we are going to cut your uterus out of your body.
Wow, that sounds very scary. So here's the thing, guys. This is what you should say. Well, ma'am, we are going to remove. Okay. I try to use not to you cut. A lot of you will try cut, but patient. Okay, if you learn scary movie or you watch too much Hollywood movie, they cut our body, right? No. You are a surgeon. You are professional healthcare. So you use. I am going to remove, okay, and then the uterus, and then you don't have to say out of your body, because when you remove, it will be out of your body, right? All right. So who else is the next one here? Let's see. I mute number 90, and then come on, guys. I haven't seen. Okay, let's see. I pick number 21. Think.
Dr. Think, yes. I'm going to do colectomy and
Colectomy. Okay, so tell me more about that. It sounds scary to me.
Yeah, we found a tumor in your colon, and we will do a surgery to remove a part of your colon that contain the tumor.
Wow. So how do I poo?
Oh, yeah, we will make you
Oh,
I don't know. I just forget the word hormone nhân tạo.
okay. Can anyone help? Does anyone know? Come on, guys, you know this. Okay. Let me ask the anesthesiologist. Okay. Does anyone come and help? Number 21. Okay, I see some hand there. Hello. All right. Did you find it?
I think all of you already learned that term. How can you forget very quickly?
So it's called colostomy, right? You should know that.
Yeah.
So a colostomy is it's a bag that and this is common in colon surgery, and you have to think about how when you approach the patient, if you want to cut their colon, their first question, how do I poo? I mean, how do I go to the restroom, right? And you have to think about it and don't just, oh, I'm going to cut it because you want to cut it. No, that, and she say, well, rest assured, ma'am, we'll find a way to make sure you can poo, make sure that you can recover, make sure you do okay. Okay. So that's something that, all right, let's do number, let's see, 72. Too full.
I think you need an vitrectomy. I'm ophthalmologist.
Oh, okay. You're an ophthalmologist. Okay.
Vitrectomy.
Yeah. Well, I got it. So why I need that procedure, ma'am?
You have a problem in the retina, and we need to do a vitrectomy to repair the scar in your retina.
Okay. Well, you're almost there. Okay. So can I see, or you have to close my eye during procedure? Can I see you?
After you have done this surgery, you need you need about several days to see normal, but
okay.
About after 6 months, we need to remove the gas or oil in your eye.
Okay. All right. So ophthalmology, I got it. Okay. So yes, I can. Sounds like it's better than, I mean, colectomy, right? I mean, I think that's better. I mean, can I imagine someone remove my colon and don't tell me the option? What else? All right, let's see.
Sorry, I have a question.
Yes.
I think I cannot hear clearly what procedure she want to perform. What's the name of procedure?
Can you say one more time? What the procedure?
Vitrectomy. Dr. Ding write in on the comment.
Yeah, it's vitrectomy. So it's such a procedure. Yeah. So where the vitreous humor get filled the eye to remove, and then they provide a better access to the retina, right? Vitrectomy. So let me type it out. Yes, vitrectomy. Yes. Now, let's see who else. Come on, everyone have one imaginary procedure, right? Let's see, number 69.
Good morning, Mr. Wynn. I'm Dr. Tu. I'm an orthopedic surgeon.
Wow, see.
Based on your clinical findings, I think you need the treatment of your wound.
Okay.
Yeah, this is the procedure that to remove the dead tissue from your wound in order to have the wound get better, or to have the healthy tissue to become more effective healing.
Excellent. I like it. So, Dr. Madam, how long the procedure will take?
I think it doesn't take too long. It's just around 1 hour.
Okay.
Yeah.
And am I in pain?
I'm sorry.
Will I be in pain when you do this procedure?
Yes, but
Yes.
we will.
Oh,
But we will give you some medication that to
okay.
let you don't feel any pain.
Okay. So will you put me in sleep?
No, I don't think so, because we will use the kind of medication that make you don't feel pain, but you don't need to sleep.
Okay. Excellent. Thank you. Thank you, orthopedic doctor. So now we have orthopedics. And just to let you know, orthopedic surgeon is one of the most competitive, very difficult to get into the US. And okay, now number 62, Nam Phương, please.
Hello, I'm Dr. Phương, and I'm going to perform the tonsillectomy.
Tonsillectomy. Why would you do it on me?
Because your tonsil is the structure in the back of your mouth, and it's become enlarged, and it make you feel pain, and you have and you get pain so many times. So I think you need to remove that.
All right. Will I be in pain?
After surgery, you maybe you feel pain. On average, people just feel pain a little bit, but if you feel pain so severely, I can give you some painkiller to make you feel better.
Okay. Will you put me under sleep for that procedure?
Yeah, yes, because it's make the surgery more safer for you. So I will give you under sleep.
Okay.
Yeah.
One last question to see. Now, I heard that if you put people under sleep, I will be losing memory later on of my life. Is that true?
No, you just I will the doctor will give you the safe medication for you get sleep, so you don't lose the memory in the later in your life.
Okay, good. All right, I like it. This is a really good number 62. All right, number, I don't know, Nga Đỗ, right? Please. Okay.
Yeah. So, hello, I'm Dr. Nga. Today, I will take you to go under the cholecystectomy. Because you have a lot of gallstone in your bile duct, so
okay.
it's make your pain in your belly, and that's cause a lot of problem for you. So today we will go to the cholecystectomy.
Okay. How long the procedure will take, doctor?
It takes about 30 minutes to do the surgery, but because you have to go under the anesthesia to not feel pain during the surgery, so it may take longer.
Okay. Well, will I have any scar? Okay, I like to wear a bikini. Do I have scar?
Yeah, I'm so sorry to say that you definitely have some scar in your belly, but luckily nowadays we use we use the laparoscopic to do the surgery, so
Okay.
it's just a small scar. Don't worry about that.
Okay, thank you. Excellent. All right, guys. One more thing I forgot to put on my slide today, actually scar after surgery, because this is the issue that you need to address of your patient. Even you are not a surgeon, but you need to tell your patient, if a surgeon about to operate on you, no matter what, there's likely will be a scar. And even with laparoscopy technology, that when they do, they open a smaller hole, they put into, you may still have scar inside the abdomen. We call adhesion. And this adhesion could be a future complication of small bowel obstruction. So you have to tell a patient a lot about those scars, but cosmetic reason is the number one people, for example, hey, you know what, I cannot wear bikini, so let's forget it. I don't want this procedure, and that happen a lot. Okay, so tell a patient about potential complication, including scar. All right, let's see. Let me pick someone else. Number 60.
Hello, teacher. And I am. My name is Dr. Bao, and
Yeah.
today I should perform you to do the cesarean section. Cesarean section.
Wow, I see second on me. Okay. So will I have any scar?
Oh yes. Maybe no. The cesarean section is. I think it's very. It's not. It is safer alternative than vaginal delivery for use and for your baby.
Yes, but what if I have a big scar on my belly and I cannot wear bikini?
Okay.
Right.
Sorry, I can understand your question.
Okay. All right, guys. So this is very common. You may have those tricky questions like, what if I have scar? What if I don't want this? So the way that you tell patient, this is for your benefit. This is the benefits and this is the risk. If we do the surgery, we do C-section, this is a safer option for the baby and for you. You say, ma'am, my number one concern right now is your safety and your baby. I do care about your scar too, but let's focus on this. Otherwise, your baby at risk and your health is at risk. And what you can say, however, your scar, because what we do is we cut along your belly line, right? So the scar is minimal visible. Okay, that's how you explain minimal visible, and you cut a nice line like a smile face. Okay, go like this, and then usually they may see it, but not as bad. And I remember my colleague, they can do even lower, so just under the bikini line. So I mean the underwear line, so patient may not see it, but it depends on you how to explain to the patient. But you have to compare the risk and the benefits, and that's all in surgery. Surgical, it's just risk and benefit, and you just tell them all the risk, all the benefits, and if you do a good job, they will listen to you. Okay, I think that's very important. You have to tell them what it is. All right, let's do one more, and then we take a 5-minute break. And then before we come back here, let's do something that I have not heard. Let's do number 83. Dr. Tran, can you share with us what procedure you would like to operate on me?
Okay, so now I'm Dr. Chung, and now we're going to perform the cholecystectomy, which is the as known as the gallbladder removal. As you know, gallbladder is a very sharp shape near the right lobe of the liver, and on the upper on the upper part of your abdomen, and because you have some symptoms of the gallstone in your gallbladder, so we need to do the laparoscopy. That means the small procedure via the laparoscopy to remove your gallbladder, and you will feel better. Yeah.
Well, thank you, doctor. Now, how soon can I eat after the procedure?
Okay. After removing your gallbladder, it's very important for you to have the that means the operation of your intestine, and it's very important to know that you need to limit the fatty some fats in your diet every day, because it will make you more like harder to digest. Yeah, but it in the first time, and after 1 or 2 months, you can return your normal diet. Yeah.
Okay. So I have to wait for 1 month?
Yeah, I think for the general health, you need to cooperate and yeah, to comply with the diet. Yeah.
Wow. Okay. All right. Thank you for the class. You guys operate everything on me, from my tonsil to my C-section to my eye and my gallbladder. I mean, wow, that's a lot of procedure, and then also my appendix. So let's take a 5-minute break. But before we leave, I'll assign you this the quick exercise when we come back, because I want the rest of this class will be fully interactive. And what we're gonna do for the rest of the classes, I want you to remember this handout I give you, right? So the surgical terminology on the procedure, but this time that I want you to do a bit more in depth. So prepare one procedure that you're going to talk in this class, and I will call whoever have not seen yet. And then I expect more. For example, this circulation using a common surgical procedure. The handout I sent to you guys a few days ago. Read that handout and I come back and make sure you prepare for a few questions that I asked. And this time I want 2 of you, one operate the other and vice versa. Okay, and I can jump in to help you guys. So we pick 2 people and then you will do it. And then the rest of the class, you try to tap in your answer as well. We try to do everything in one time. Okay, guys, I see you guys back in 5 minutes at 7:12 California time. All right, hello class. I think we are back. And let me see. Well, we have 2 more people joining us. Welcome. And this is the last section, and this is also the last hour for this class. Okay. Well, you know that in the okay. So 1 question, 2 questions. Oh, I love this answer. Wow. Okay. Sounds good. Like the majority of you. Okay. All right, so this is where you can ask me or you can talk to me in Vietnamese, because let's see what we have here. The majority of you guys, 67%, understand more than 50% what I say today, and then a quarter of you really understand everything, which is good. And then about 10% of you understand less than 50%. Oh, so there's no one don't understand at all. There's also that, which is good. All right. Okay, let's see. And then, okay, guys. So before we move into the in-class exercise, I'm going to pair one of you guys with the other one, and one the surgeon, the other one is non-surgeon or patient. Any question or any comment so far? Do I speak too fast? No? Okay, some of you say no, some of you say yes, or okay. Okay. Now, guys, I really want feedback from you, okay? And from what I see, you too nice. My students usually not nice. They say, Dr. Tran used too fast speaking, and I have to slow down, okay? But I want you guys give feedback on us to see what else we can do. All right, so I need 2 volunteers, and who haven't, let me pick some number here. Why don't we do number 29? Okay, 29, you are a patient, and then number 15, you are the surgeon, okay? And then vice versa. Can you do 15 and 29? So you two will do, okay? All right, go ahead.
Yes. I now today we perform a breast biopsy.
Okay.
Biopsy is a procedure to remove tissue from breast. Breast tissue. So this procedure will need to do the extract tissue or alone, maybe particularly or completely remove from examination or treatment.
Okay. All right. So let's see. Number 15, you are the patient now, and then you can become his surgeon in a second. Okay. So you can ask him what question you would like to ask. 15, 15.
Yes. How long will I have to stay in the hospital after surgery, doctor?
This procedure is just in a short time, maybe 3 to 5 minutes. So you don't need to stay in hospital.
Biospy, like you take some tissue in my breast, or I have to cut on my breast?
Just this procedure is just remove a tissue, breast tissue, not cut.
Not cut at all.
Yes.
Okay. It pain or not?
Okay. All right. So just time out 1 second, guys. You need to tell the patient why you need this procedure, right? So usually breast biopsy done because we found something on your mammogram. You can say, ladies, ma'am, we found on the mammogram that there were spots that were concerning, that we need to take a tissue sample from your breast to look under microscopy to make sure this is cancer or not. This procedure called biopsy, like you just said. And yes, you can, and I mean, the patient, I miss 15, right? You have great question. Those are the biggest concern. And then for women, actually, another question, how deep or how big the scar you will left on my breast? And this is very common. You have to address, because the answer is usually is very small, because usually they do FNA, they do fine needle aspiration, or if they do a surgical biopsy, usually they do a tiny one. But the FNA a lot of time can tell you what it is, or they can do ultrasound guided procedure. They get a tissue sample from that. All right. How about 15? You are a surgeon now, and you operate on the number 29. Go ahead. Go ahead.
Okay. Hello, hello, I'm a nurse. I'm on behalf of Dr. Wynn, because he have another meeting, so that's why I stay here to announce to you about your situation right now. We are going to perform appendectomy for you. An appendectomy is a surgical removal of the appendix. In the result of ultrasound, we saw you have appendicitis, and that is and in the blood test, CPR really high. CPR is the amount of infection. That's why we make a new decision to you to have the appendectomy.
So time out 1 second, and then like go ahead, 29. You have any question?
After appendectomy, to me, when what time I can eat again?
Maybe because you we will have endoscopy to you, and under general anesthesia, so you can eat after 12 hours, but live food, that is a small meal. I will give you a porridge before. I will give you porridge, and after that observe you, and then I will give you a whole meal.
Hey.
And don't worry about being hungry, because we give you the IV catheter and IV nutrition to you during anesthesia and after and post surgery. Do
All
you
right.
have any?
Okay, any questions for
I have
yeah,
I have
go
a
ahead.
question. So what about scale? What's my scale in the field of surgery when we do it into? Yeah.
What do you mean? That means scar?
Yes, the scar is that big or small?
Okay, that is the really tiny scar. Honestly, you will have a three tiny hole in your belly, but I think in the future maybe you only have a small scar, but don't think about. I think many students scare about the scar in your belly if you want to wear bikini on the sea, but don't scare. That is a tiny scar for you.
Okay. All right.
Sorry, Professor Wynn Tran, can I have a question for you?
Yes, go ahead.
I'm Dr. Thor. I'm
Yes.
endocrinology. So
I remember that.
in my department, we have a thyroid patient, and we use FNA for the note of thyroid. So like breast biopsy, I want a question to you. When we take FNA or thyroid biopsy, can we remove cell cancer cell to the normal thyroid when we process FNA for patient?
I don't quite understand your question. So you asking the FNA can remove cancer cell in thyroid nodule, or what is?
Yes, like that, because we example a patient have a cancer tumor in thyroid, so we put we FNA to this.
Yes. Okay. So usually what we do here, I refer to, yes, the endocrinologist, and you guys do FNA. However, if this is a thyroid, so remember we score the thyroid nodule with thyroid 1 to thyroid 5. which is number 5, is highly suspicious for malignancy. In a lot of cases, we do FNA. We try to get a sample from the cell, and if it's concerned carcinoma, usually we refer to the ENT surgeon so they can remove the entire lump. They can do thyroidectomy, or they can talk to the general surgeon as well, and usually that's the procedure we done here. But to answer your question, yes, FNA, that's the way that we can figure out whether that's cancer cell or not. However, you have to realize that FNA have to be precise, because if you miss the tissue, you get a benign tissue next to the cancer cell and you come out as negative. It's a false negative. It's not. So sometimes, a lot of time, what you do, make sure they do enough sample. But let me go back to this class and try to pair you with someone else. Let's do number 61 is, okay, now you're gonna do procedure. And let's do you and number 06, Dr. Tung. Okay. Dr. Tung, you ready? And then Dr. Tai Thor, you guys ready? So one of you are the surgeon and one of you are the patient, and you can go first.
Yes.
Okay, thank you.
Yes.
So can I, doctor?
Yes, you are a doctor.
Okay, thank you. Okay. Hello, Miss Thor. I am the Dr. Tung. I am a doctor for the surgery for you right now. Today I want to explain something about the surgeon, about the medical condition, your medical condition. You okay?
Yes. Hello, Dr. Tung.
Today I want to discuss about the appendectomy. Is about the surgical removal of the appendix. Is when you had in the abdomen, you had a small toe, that's the branches of the larger intensive, and when it's the inflammation, so we can to treat this when we to treat acute appendicitis. It means we can treat the acute appendicitis. Appendicitis is the acute inflammation of this tube. So I think we can remove this. It's about a surgical. We can go in the OR. It means the operating room. We had the few hours to to remove this appendicitis.
Sure.
Okay.
Let me time out 1 second between number 6 and number 61, right? Now, you guys, why don't you give your patients some time to listen to you and answer the question, and right? For example, you say, hey, Mr. Thor, we're going to remove your appendix today. And you stop right there. You let Mr. Thor think about it. Okay, he may say, wait a second, I don't want you to remove my appendix. I love it. Okay, so yes, wait for the patient to respond. Okay, and then we go from there. So let's keep going. And then Mr. Thor, what do you think?
Yes, thank you, teacher. I think so, because I very worried when have a appendectomy, and I want to ask Dr. Tung, can I teach my not opera? And we use antibiotic for my disease.
Yes. This acute appendicitis is when the tumor in your abdomen is the inflammation. When you don't remove it, we can have the maybe have sicker. We have the blood sepsis, but maybe you can die. So I think we should remove the appendicitis as soon as possible.
but I have a history of allergies.
Allergy.
I have
What kind
allergy
of
with penicillin. So I got it
penicillin? Okay.
penicillin. I allergic with penicillin, and I got it when I have a operation.
Operation. Yes.
Okay.
Yes, yes, I understood. I think when you had the analysis and penicillin, so we can do not use that kind of drug for you when after operation. I think when we can use another antibiotic after appendectomy, so you don't worry about the drug. Yes, I read about the medical history about the analysis. Thank you.
Thank you, doctor. And you are directly opera for me.
Sorry, can you repeat?
You are operation for me.
Yes. I'm your surgeon. Yes, I doctor
what I prepare for this. What I prepare for this.
Yes. To prepare before the operation, I think you don't eat anymore. At least 24 hours before the operation. We had the test. We had the external test for you before we had the operation room, like the blood pressure, had the blood test. Maybe after that we can have prepare you change your clothes. We had something about for yes. I think the nurses will talk to you about when you need to do and don't to do after that. So you don't worry.
And in my family, who must come with me?
No. I think your family can you wait in outside the operation room. I think in Vietnam we can up to date for your condition and operation is hours. So if necessary, I can talk your families members.
Thank you, doctor.
Excellent, Dr. Tung. I like to tell you this is really good. Even though you give small sentences and very patient, I like it. The way that you explain things calmly. Guys, when you talk about procedure, you should be very calm and reassuring your patient. You don't want to show overconfident. You don't say, "Hey, I'm the top surgeon. I operate this and that." No. You talk in a professional manner, and I like how Dr. Tung walk in. He talk slowly, and he calmed the patient down. He say, "Yes and yes. Well, we can update with your family member during and after the procedure, and make sure all questions are answered." Okay, I love it. This is nice. All right, let's do the reverse side now. Dr. Thor, you are the surgeon, and then Dr. Tung, you are where's Dr. Tung? He just disappeared. Okay, Dr. Tung, you're a patient now. So now it's your turn, Dr. Thor. What kind of procedure you want to operate on Dr. Tung?
Yes, and hello, Miss Tung. I am Dr. Thor. Today, I want to talk to you about your disease. And as you know, you have you have a small tumor that brain of the large intestine. That is inflammation. So I think we should appendectomy do dizzy.
Okay, thank you. Can you explain for me what kind of appendectomy for me, please?
As like that, you have inflammation of the parts of the body. So we remove the inflammation tissue from the body.
Okay, thank you.
Okay.
Because I very scared of pain. So we had another way can don't surgery. I think I'm very scared of pain. I'm very scared of blood. What kind of or another adjustment?
Like many people like you, they are very obsessed about blood and about pain. But we have a team in operating room, so they can help you not pain when we the appendectomy for you.
Oh, thank you.
All right, very good, guys. So this is what I love to hear more, but I wish we have a lot of time so I can sit all day, just listen to you guys try to operate on each other. Okay, and I think it's kind of fun that some of you want to do a C-section on me, which is unfortunately that's not going to happen because I do not have a uterus. But okay, so let's pick another pair that I like to hear. Let's do I haven't. Okay, number 73. You look very serious, Dr. Tai. And then let's pick number 36. Let's do 36 and 73. Go ahead, Dr. Tai. You are the surgeon now, and number 36, Miss 36, Miss Ngọc is your patient.
Okay. Miss Ngọc, can you turn on the micro? Yeah, okay. Hello, Miss Ngọc. I am Dr. Tai. I'm a gastroenterologist. And based on clinical findings, I think you have a severe ascites. So I need to do ascites synthesis. Did you have any question for me?
Can you explain what it is?
Yeah, ascites, that means that so much fluid accumulation in the abdominal cavity. So I will put one needles in your anterior wall of the abdominal to remove fluid out.
Oh.
If I not do this, you will difficult to breathe. Yeah.
Okay.
Do you have any concern?
And it is pain?
A little bit. It's not a sharp pain, but you feel a minor pain in your anterior wall of the abdominal.
Okay, and after that, it is make me feel pain or hurt?
When I finish this procedure, you don't feel pain at all. You just relax in at your bed, and you can walk around after that.
Okay, can you tell me what I can do after that to make my health better?
It's a long-term treatment, so with that procedure, I just remove fluids from the abdominal cavity. Just will help you feel better, and after that, I will prescribe for you some diuretic medication so that you can pee more and relieve the symptoms.
Good. Okay, I like the interaction between you two, and remember, you give your patient small sentence. and wait for her response. In this case, Dr. Tai, you did an excellent job. I like to tell you that you come and you tell patient about the incoming paracentesis. I mean, the procedure you want to remove the fluid from her abdomen. Now, in your return, Ms. 36, now you are the surgeon. And then what would you like to operate on Mr. Tai?
Hello, Mr. Tai. I'm a plastic surgeon. Based on your clinical, I think you maybe I think you may need an rhinoplasty.
Okay.
Because
Rhinoplasty. Okay.
Okay. Because because you want to make your face more beautiful, so you come to my hospital and want to make plastic search to make a rhinoplasty.
Okay.
And we shaping the nose teeth of your nose. And do you have any question for this?
So how long does it last?
I think it's maybe last 1 or 2 hours.
I see. And can you tell me some complication about this procedure?
Sorry, can you repeat the question?
Any complications after surgery that I will suffer from?
This surgery is very safety for you, and it's simple for the doctor to do this. We just use the comfortable material to make your nose longer and I don't know how to say it.
Okay. Well, I like the interaction so far, but just a few comments. A rhinoplasty, it can be an elective procedure or it's a medical procedure. So elective procedure, when the patient wanted to have this procedure done. In this case, Mr. Tai would like to have a more handsome face. That's why he decided to have his nose rebuilt, or that's how you say, or rhinoplasty. However, in case of Mr. Tai have a septum deviation or have a surgical trauma or any type of accident that subsequently damage to his nose, and yes, you can use this procedure to rebuild his nose. So you can approach in 2 ways. Either this is an elective procedure like the patient wanted to do, or this is a medical procedure like is needed to be done to improve the patient health. Now, I did not mention here, but it's for time limit. But one of the most complications from surgical procedure is infection. So I want you to think about it and tell your patient a little bit about that, because infection is very common, and in many cases, or in people with severe immunocompromise, infection can be so severe it becomes fatal. The patient may die from infection. So those are the things that you need to address with your patient. All right, let me do a couple more, because I cannot tell you how fast time is really flying. 7:43 already. All right, number 59, and then number let's see, 53. Okay, let's do this.
So I will be the doctor.
Yes, you are the doctor, and then 53 is the patient. Yes, go ahead. What would you like to operate on him?
Okay, so I couldn't see her name.
53 is
I'm here.
Dr. Hui.
Hello, Ms. Tran. I'm Dr. Wynn, a general surgeon. Today, I would like to talk to you about the disease. Would you like to come with me alone or with your relative?
Excellent.
All right, sure.
Is that you want to go with me alone by yourself, or you want to go with one of your family member?
I can take it alone.
Okay, as we discussed last week, that you have hemorrhoids. So you complain that it makes you very painful when you pass the stone, and it have a bleed in your stone. It's very uncomfortable. So I think this time we will do the hemorrhoidectomy for you.
All right. Can you tell me more about what you are suffer from, or if there's any bad effect from that surgery to me?
So basically, we will help you to remove the distended vein in the lower rectum. So by doing that, you will stop have a red blood in your stone, and you will be you will stop painful. You can sit down comfortably, and it doesn't affect your quality of life at all, like before.
All right. So does this have any it's make me difficult to do my daily activity, like go to take a shower or anything like that?
Yeah, I think that at the beginning, that after we did that procedure, you may feel a little bit tired, and it's difficult for you to do some kind of activity to take care of yourself. And so you may need someone in your family to help you with that.
All right. So how many days I can get back to my work after that surgery?
As normal, as I observe in many patients, that it only takes for 3 days or maybe 1 week for you to go back to normal life.
All right, sure. Yeah, thank you, doctor.
Do you
thank
have
you
any
for giving that information. Yeah.
Do you have any further question? Do you have any other concern?
No, thank you. I agree to take that surgery.
Thank you.
All right, very good. I love it. I think that the end of the class, everyone doing much better. Okay, now your turn. Number Mr. 53 to 59. Go ahead.
All right. So pretend that I'm a doctor. You are the woman who get a tumor on your uterus. So I'm gonna tell you something. Hi, Mr. I can see your name.
Okay, my name.
Yeah. Hello, Miss Vanai. How are you doing?
Yeah, I'm a little bit nervous. I don't know what happened to me right now.
Yeah. I think you should take a deep breath, because we are going on a very serious conversation. I'm the Dr. Hui, your general surgeon, and today I will
Are you looking for a way to
tell you something.
help, but don't?
Yeah, I'm ready.
Yeah. based on your clinical finding and some labs laboratory tests, we think you may have a tumor on your uterus, and we are considering that you may have to get a hysterectomy.
Already, it sounds seriously to me. Can you tell me more about that?
All right. That proceed that we remove your uterus. I think that are big surgery, and it will lead to it will lead to you can be pregnant anymore. You can have children anymore.
It's sad for me. So, is there any other option for me?
Yes, but I think doing the surgery that the best way to your health, because if we don't remove the tumor, it will grow bigger and faster day by day, and it will cause a lot of bad effect to your health, and it may reduce your lifetime.
Is that a cancer or not cancer?
Yes, it's a cancer.
So you said that is the only way to make me better with my health, right?
Yeah, I think there are lots of other treatment, but it's just like a supportive treatment, not a not a best way to remove to increase the pain.
So if I have to remove my my uterus, so how long would I live? And if not, how long will I live?
Yeah, after surgery, you will take care of you for a week. After that, you will back to your home and do some recovery at home.
No, I mean that is how long I will live. Like what about my expectancy after I had this operation? How long?
Do you mean how long?
How much of time do I have?
Yeah. I think the surgery will have you have more 5 years compared to if you won't take this, you only have maximum years 1 year.
Okay, it seems very big decision for me. Yeah. So
great discussion. Yeah. Thank you.
Sorry. Yeah.
I'm sorry to just time out real quick, but I like to. You two did excellent job. I think the way that you interact, but in general, it's common rule. If you don't want, you're not sure, you can always talk to your patient. Hey, you know what? There are two options, right? One, we operate. The other one, we don't. And we make sure that we give the patient the option not to operate. This is like alternate, like no procedure. Then what will happen? Like you explain. So I think that's a good to start. But in general, if you don't know for sure, I will not give a time frame. You just say, statistical speaking, similar case like you may survive in this year. I will not say this is a patient you will survive 5 years. I would say, based on the statistical study or based on statistics, a patient with similar condition like yours may expect to live about 5 years. That's why I would say, if you really want to give a number.
Yes.
Well, for two reasons, they can sue you. I'm not sure. Someday in Vietnam, patient will sue you. Right now, you guys enjoy a lot of. I know extremely hard to sue a doctor in Vietnam, but in the US, this is you say something, and then it won't happen, or it did not happen. You're fully liable for what you say as surgeons. So, but I'm not talking about legal. I'm talking about you try to communicate with your patient. All right, so let's do one more pair before we move on to, okay, let's do number 44. I haven't heard anything about 44. And then let's do a pick number, let's see, number 77. 77 and 44, okay. Oh, number 77, are you in the OR? You look to me like you in the OR now.
Yeah.
Hello. Hello,
Okay.
I'm Ngọc. I'm Doctor Orthopedic and Gynecology, and I say today you say you have a cesarean section for because you have Oscar the last delivery, and I this procedure in I am. We transfer incision in abdomen and take baby baby out, and I think the cesarean section safe for you and baby.
Okay.
Okay. So how does it last?
Sorry, can you speak again?
How operation?
Operation abdomen and uterus cesarean section take maybe your in your uterus go out.
Can you repeat your question, Mr. To the surgeon? You can ask again. Okay, let's see. 77, are you still there? All right. So I think the patient actually, for some reason, you perform a C-section on him, and he not responding. Right? I mean, that is. Oh.
I'm sorry. He is a man, and I say the question for the female.
No. I'm just teasing you. I think he will come back, but this is like we have a cold blue doing procedure. Anyway, let's find another pair, and then number 44. Can you pair up with number? Let's see, what's the number here? You know what? Why don't you guys volunteer to say that? This is like we have few minutes left. You guys too nice, too shy. Don't say anything. Okay, raise your hand if you want to. Let's see.
Okay, and I make a pair with the number 44?
Yes, please. Okay.
Thank you, Dr. Nga.
Yeah.
You're welcome.
Hello, Mr. Nga. I'm Ngọc, and I am Doctor Orthopedic and Gynecology, and I say you today you cesarean section for you, and I take the baby your uterus go out.
Okay. Oh, so Dr. Ngọc, can I ask why cannot I delivery as usual at another mother? Why I should take the C-section?
I think the cesarean section good for safe for you and for baby because the baby is big and you small. I'm sorry, you small.
Okay.
Small, and not I think baby cannot go out the vaginal delivery.
Oh, thank you. So is it pain during the surgery?
When the sterilization doctor anesthesia for your skin skin pain and you feel no pain.
Oh, thank you. And I have a big concern that's there any risk for my baby if I go under the C-section.
When baby sterilization not good for not good than vaginal delivery. Baby can breathe slow and cry slow.
Oh, really? So that's very dangerous for my baby. So you mean that it is dangerous for my baby or not? Sorry.
You don't worry. When baby go out and doctor pediatric have baby breast and for baby oxygen and have cái thở là gì mình quên mất cái từ đấy rồi.
Have the baby with the breathing.
Have baby breathing.
Yeah. Oh, good to hear that. Yeah, thank you so much.
All right, good. And now it's Miss Dr. Nga. It's your turn to operate on Miss Ngọc 44.
So, hello, Miss Ngọc. Yeah, nice to see you again. How are you today?
Today I'm fine. Thank you.
Yes. As the last time you come to me with a complaint about your breast, has something inside your breast that make you worry, right?
I think you don't you don't worry rise of your breast. You do you feel pain?
Chị Ngọc ơi, đang đổi lại. Em đang hỏi về cái lần trước mà chị đến thăm em ấy, mà chị complain, tức là chị than phiền về cái việc là có một cái khối gì đấy ở trong ngực của chị. Yeah. Yeah. Do I say clearly to you? Okay. Okay. Don't worry. Yeah. So, according to the examination we make and the ultrasound, so that you have a tumor in your breast. And we already take the biopsy, and it said that I have to say that it is a cancer.
I worry in my breast, and
Yeah. Do you take my information to I give you? That's the test that so that you have the breast cancer.
After you say me breast cancer, and after you take me remove my breast.
Oh yes, exactly what I want to say with you today is we have to remove your breast tissue. Yeah. To save your life.
I was say you, and I stay in hospital for day.
Yeah, today you should take in the hospital so we can do some blood test to prepare for the operation. Are you ready?
Yeah, I ready, and after a post breast biopsy, and what how many time, and I go work. Tức là đi có thể đi dậy đi bộ được ấy.
So you mean that post-operative, what time you can stand up and walk post-operative? Okay,
yes.
So is it because of you go under the anesthesia? So
Yeah.
it take you 6 hours, and after 4 hours, you can sit up from laying out to sit up, and after 12 hours you can stand and walk around the room.
Yeah. Thank you, doctor. And what medicine I give in the post breath biopsy?
So because it is a surgery, so we give you antibiotics to prevent inflammation. We give you the pain reducing that make you relief and help you to feel no pain. And also we give you some extra fluid to nutrition, because you cannot eat before the operative 6 hours, and after that you cannot eat immediately after operation.
Yeah. Thank you, doctor. Very clear information.
Yeah. Do you have any question for me?
And I think your information enough to me, and thank you.
Well, thank you guys. Thank you, you two, especially.
Yeah, you're strong and brave.
Good. Okay. So with that, I think the class just officially ended, but I like to spend a couple more time with you guys to go over a couple things. Dr. Dean will send you a product presentation and then a link to video tonight or tomorrow. Well, this is the time that for us to talk about the class, and it is my pleasure to know all of you. I remember I did 3 sections with all you guys, right? The introductory, and then the oncology, and the surgical one. But this is the time that I like to hear from you. I like to see what else we can do. And let me ask you just one question. Do you feel this class helpful? Yes. In what way? And here's the thing, I give you a bonus, okay? Anh chỉ có thể nói tiếng Việt với tôi. Okay, you can speak Vietnamese. It's okay.
Can I say something?
Yes, please.
Yeah. I think this course is really helpful for me. Actually, in the past, I have learned medical term by myself, but actually, I just learned the prefix, suffix, and root, and how to I read the book in English, but I don't really want to practice speaking and listening. So after this course, I know that the pronunciation and the speaking practice is really important in medical English. And thank you so much for teaching us about the right appropriate pronunciation and how to practice speaking. Thank you so much.
Oh, it's a pleasure to see and to hear. Who else? Feel free to speak out your mind, and we are listening. Me and Dr. Dean, and I think Dr. Minder was also listening. We like to improve. We like to retain our number of class. When we start with 100 students, and now today we have 31, so the majority of people joining this class, they, for some reason, they did not finish this last day. To us, we feel like we did not fully do a good job, even myself. So I like to see what else we can help you guys, what else we can do, and comment very appreciate that. So whatever you can say, you can speak, as I say, in Vietnamese. We understand that, no problem. And I hope It was a fun section when you talk to me. I love interaction with residents, with fellow, with students, and this is how we like to talk to you. Okay. Who else?
Thầy, em xin phép nói bằng tiếng Việt.
Oh yes, please.
Em thưa thầy và các thầy cô, em đã từng học các lớp về tiếng Anh y khoa, có nghĩa là phải trên 2 lớp, và em thấy cái lớp học thực sự là bổ ích, nhưng phải học đi học lại một bài thì mới đủ thời gian để hiểu hết đấy ạ. Tức là một chủ đề của việc một bài về một chuyên khoa ấy là bản thân em phải học đến có khi phải đến 3 buổi tự học lại thì mới nhớ nổi hết số terminology trong một bài ạ. Thì nếu mà khóa sau chắc là với thời lượng 2 tiếng thì các thầy có thể thu cái bài giảng nó ngắn hơn ạ, và thì bọn em mới tiếp thu được. Và trong quá trình học thì đến bây giờ thì sau 14 buổi em nghe được em nghe tốt hơn nhiều, và đọc tài liệu thì cũng tốt hơn nhiều, nhưng mà từ thì rất nhiều luôn ạ. Em vẫn quên, em vẫn phải để hết trước mặt luôn ạ. Em phải để hết các bài giảng và những cái từ mới em phải để xung quanh người để có thể nhớ. Và đấy là em rất tập trung để học nhưng cũng không tiếp thu được hết đâu ạ. Vâng ạ. Thì một cái góp ý là em hy vọng là nếu mà khóa sau thì cái trong vòng 2 tiếng thì thời lượng cái nội dung của bài giảng có thể ngắn hơn, và có thể thêm một vài cái video game về giao tiếp thì bọn em sẽ nhớ hơn ạ. Thế còn số lượng từ, khi mà em học ở lớp mình thì em phải sử dụng cái quick plus, tức là một cái học từ mới ấy. Thế nhưng mà em vẫn nhớ rất là khó. Vâng ạ, đấy là suy nghĩ của em ạ. Em cảm ơn thầy.
Thank you, thank you. Có anh chị nào có ý kiến nữa khác không ạ? I can speak Vietnamese if you guys want to.
Dạ, em cũng xin nói tiếng Việt. Tức là em bắt đầu lớp học này thì tức là trước đây thì em không phải học chuyên ngành bằng tiếng Anh mà học tiếng Pháp. Thì bắt đầu với lớp này cũng khá là khó với em, nhưng mà hiện tại thì mình cũng thấy là mình có tiến bộ, cảm thấy mình tự tin hơn, và cũng là do là các thầy rất là nhiệt tình và em rất ngưỡng mộ về trình độ chuyên môn, về tâm huyết. Nói chung như thầy Đinh nói, tức là chỉ cần là sau này các em hướng dẫn lại các thế hệ sau là thầy vui rồi. Thì cái câu này rất là làm em rất là xúc động. Yeah. Thì đối với các thầy cô khác thì có thể nói tiếng Việt nhiều hơn, nhưng trong bài của thầy Wynn thì nói tiếng Anh nhiều và nói nhanh thì đôi khi em cũng không hiểu hết được. Nhưng mà em cũng rất biết ơn thầy, vì tức là ngoài cái giờ học này á thì em cũng vẫn xem kênh của thầy. Tức là kiến thức của thầy rất là rộng. Và trong cái bài 2 thì em cũng tức là có rất là nhiều chuyên ngành, nhưng mà có một cái chuyên ngành mà em cũng gọi là bị ấn tượng, tức là lifestyle medicine. Tức là cái này thì em chưa thấy ở Việt Nam, nhưng mà hình như có đào tạo ở Mỹ, thì em cũng muốn tìm hiểu về chuyên ngành này. Thầy có thể giới thiệu thêm cho em được không? Với lại là em cũng rất là buổi đầu giờ á, bởi vì là thường các bác sĩ hay là cán bộ y tế của Việt Nam á, thường tập trung vào chuyên môn, nhưng mà rất là thiếu nhiều kỹ năng, ví dụ như là quản lý thời gian hay quản lý tài chính, đại loại là những cái kỹ năng khác, kỹ năng mềm ạ. Thì thầy cũng có nói là chúng ta phải cần học thêm, đúng không ạ? Dạ vâng. Em cảm ơn các thầy rất nhiều.
Vâng, tôi cảm ơn các anh chị rất là nhiều, tại vì đây là tôi đi dạy những cái lớp như thế này cũng trên 10 năm rồi, và mỗi lần đi dạy nhìn lại đã thấy là mình thích cái nghề này hơn. Một trong những điều quan trọng nhất mà mấy anh chị có thể làm là cố gắng thực hành. Tại tôi biết là cái khó của chúng ta là chúng ta không có thực hành tiếng Anh, và khi mà không thực hành thì nó sẽ quên mất. Có nghĩa là ngày mai và tuần sau nữa là những cái từ tôi mới nói mới đây mọi người sẽ quên mất. Nhưng mà anh chị nhớ là anh chị rất là nhanh, rất là giỏi. Chỉ cần nghe cái bài giảng của tôi tới lần thứ 2, tôi tin là phần lớn anh chị sẽ hiểu cái từ đó. Nhưng mà chúng ta không có áp dụng, thành ra chúng ta mau quên. Thì tôi nghĩ cái đó vẫn là cái vòng lẫn quẩn, là chúng ta đi học nhiều quá mà cuối cùng chúng ta không thực hành tiếng Anh chuyên ngành. Thì hy vọng là anh chị nào đang học cái khóa này tiếp tục giữ liên lạc, tham dự những cái bệnh viện quốc tế, hoặc là viết bài tiếng Anh, hoặc là thỉnh thoảng chúng ta có một cái chương trình nào đó để mà VietMD sẽ luôn hỗ trợ quý vị để tạo ra những cái hoạt động như vậy. Cái việc mà quản lý thời gian là một cái chủ đề mà tôi thích giảng, là tại vì sao? Tại vì cá nhân tôi và nhiều bác sĩ mà tôi dạy ở đây, thật sự quý vị muốn thành công, tôi nói một câu rất là đơn giản là phải quản lý cuộc đời của mình, và chúng ta phải biết quản lý thời gian, và nhất là những người chuyên ngành như chúng ta càng phải biết quản lý thời gian hơn nữa. Tất cả gì mà những người thành công mà chúng ta thấy và ngưỡng mộ, có một điểm, họ có một điểm chung là họ quản lý thời gian họ rất là tốt. Vậy thì tại sao bác sĩ chúng ta không làm được cái đó? Thì tôi nghĩ là cái đó là cái mà hy vọng là quý vị, mấy anh chị này có đủ quan tâm thì tôi sẽ làm một cái lớp riêng về cái quản lý thời gian đó, bắt đầu từ những cái việc rất cơ bản như quản lý về cách suy nghĩ về tài chính, về thời gian. Tôi nói ví dụ như là cái thời gian mà chúng ta còn sống trên đời này, nói thì nghe rất là ghê, nhưng thật sự khi quý vị nghĩ tới đó, quý vị sẽ thấy là cái việc quản lý thời gian rất là cần thiết. Ok, tôi nói tiếng Việt như vậy anh chị có hiểu không? Có cần phải làm một cái survey rồi hỏi là tôi nói có quá nhanh hay không?
Không ạ, thầy nói rất là hay ạ.
Dạ thầy, cho em hỏi về cái lifestyle medicine ở bên Mỹ, tức là về điều trị thì trong cái thời gian mà suốt 6 năm mà em học về chuyên khoa y thì các thầy chỉ học về điều trị là chính. Tuy nhiên là cái lifestyle medicine em tìm hiểu thì nó có thể giúp mình phòng bệnh, thì cái này sẽ rất là tốt, gọi là cho cả y bác sĩ, tức là nếu mà người bệnh không có bệnh thì sẽ đâu đến tìm mình nữa.
Vâng, cái đó sẽ là một cái có thể là chúng ta sẽ nói riêng hơn, tại vì bây giờ tôi đang cố gắng tập trung vào cái lớp này, nhưng mà nói trong vòng 30 giây thì đó là một cái chuyên khoa mà đa số những bác sĩ về nội khoa hoặc là bác sĩ gia đình có thể đi chuyên khoa này, hoặc là những bác sĩ chuyên về nội tiết, những chuyên khoa mà có thể liên quan tới dinh dưỡng. Thì những chuyên khoa này là những chuyên khoa chú trọng nhiều vào cái việc ngăn ngừa bệnh. Tôi nói ví dụ nha, khi tôi nhìn với anh chị đây nha, thì tôi khai đoán được dựa vào hình ảnh thôi nha, là cái lifestyle anh chị nó như thế nào. Cái này không biết là có anh chị có bao giờ học cái khóa này không, nhưng mà tôi nói cái nghề thứ hai mà bác sĩ có thể làm, quý vị biết là nghề gì không? Là nghề thầy bói. Tại vì tôi bói phần lớn công việc của bệnh nhân của tôi dựa vào cái ngày mà họ bước vô phòng thôi. Tôi nhìn cái đồ họ mặc, ngửi cái mùi nước hoa của họ, nhìn cái bàn tay của họ, nhìn cái cách mà họ cầm viết, nhìn cái cách mà họ ngồi, chúng ta đoán được họ bệnh gì rồi. Không biết quý vị có học cái môn này không, nhưng mà ở bên Mỹ này có nó gọi là cái khóa mà quan sát bệnh nhân. Thì phần lớn là tôi được quan sát bệnh nhân, nhất là xuống phòng cấp cứu chỉ cần đi một vòng là biết ai bệnh nặng, ai bệnh chưa nặng và ai bệnh sắp nặng. Thì cái khó của người làm y khoa là chúng ta biết được, có thể là thấy được cái đó. Ví dụ đơn giản nhất là của cái lifestyle medicine là ví dụ như chúng ta thấy bệnh nhân cái tư thế ngồi chẳng hạn, ngồi mà không có thẳng lưng mà ngồi cứ khom lưng là đó, đau cổ, đau khớp nó sẽ gặp thôi. Đó, những cái gọi là lifestyle medicine từ cái chỗ đó mà người Việt Nam mình đôi khi thì chúng ta không có chú ý nhiều tới những cái tư thế nè, thậm chí cách ăn, đi ăn mà ăn vội vàng, vừa ăn vừa cầm cái điện thoại. Quý vị biết không, tôi thấy nhiều bên đây cũng vậy, có nghĩa là hai người đi vô tiệm ăn rồi người vợ chồng người đứa cầm cái điện thoại gì quẹt rồi cái kia cầm cái ăn như thế này, là cái đó là chưa gì là sẽ có bệnh bao tử đó. Lifestyle medicine là ngay chỗ đó đó chị. Thì những cái cuộc sống này nó ảnh hưởng đến cái bệnh thì nó nhiều lắm, nhưng mà nó tóm lại là tất cả những đòi hỏi quý vị có một cái nền tảng y khoa vững, thường là về nội khoa, và kết hợp với cái quan sát, kết hợp với cái cách mà mình giống như tư vấn cho bệnh nhân mình cái cách sống. Thường là khách hàng của những cái chuyên khoa này thường là những người giàu, những người hoặc có những bệnh mãn tính. Tôi nghĩ cái thị trường là bên Việt Nam là chắc là sẽ cao lắm. Việt Nam tôi thấy là có vẻ như có nhiều người giàu và người ta cần cái sự chăm sóc sức khỏe cá nhân cụ thể hơn là bây giờ tôi muốn có một cái phác đồ làm việc điều trị dành riêng cho tôi thôi. Thì tôi nghĩ là nếu mà chị đi theo cái hướng đó có thể là một cái hướng thú vị. Ok, bây giờ quý vị cho tôi biết những cái ý kiến khác để tôi và bác sĩ Minh và anh Đinh để chúng tôi cố gắng làm một cái khóa sau này nó tốt hơn. Thì một trong những điểm quan trọng là quý vị nào ở đây muốn học khóa 201 Dĩ nhiên chúng tôi welcome và tiếp tục, nhưng mà 201 thì tôi sẽ để cho bác sĩ Minh nói chút xíu về 201. Anh Minh nghe nói là nguy hiểm lắm phải không Minh? Anh Minh, so please go ahead, Dr. Minh.
Cũng nguy hiểm chút thôi chứ cũng không nguy hiểm nhiều lắm. Nghe rõ vậy hả?
Okay.
Rồi, rồi thì hôm bữa cũng có nói sơ qua chút xíu rồi, nhưng mà bữa nay thì nhân buổi cuối thì mình cũng nói cho kỹ hơn thôi. Thì hồi nãy cũng nghe mấy bạn còn cô trọng lại của lớp này, đúng là có nhiệt tình hơn, cũng có kỹ năng tiếng Anh khá hơn, chắc là khá hơn thành phần mà rơi rụng phía trước. Với là chắc chắn là có cái quyết tâm rất là cao. Thì hy vọng là sẽ tiếp tục được đón tiếp các bạn trong lớp tiếng Anh 201. Chỉ có điều là sẽ ngoài một phần ưu tiên của lớp mình, nhưng mà vẫn phải có cái mức độ công bằng với những người khác. Thì cái lớp sau nó sẽ yêu cầu chuyên môn tiếng Anh nhiều hơn, sẽ trao đổi trực tiếp nhiều hơn, cho nên là sẽ có những bài thi kiểm tra trình độ để mình đảm bảo là cái lớp học nó trôi chảy hơn. Thì đó là cái yêu cầu của cái lớp học. Mình cũng đang dự tính thôi, sẽ bàn thêm với bác sĩ Wynn, bác sĩ Dinh, có thể có một số chỗ dự tính được hay không thì để cho những bạn nào vẫn còn quyết tâm muốn theo, không học được nhiều học được ít, ví dụ vậy, thì để mình nghiên cứu thử coi sao để nó không có ảnh hưởng đến cái hoạt động của lớp. Rất là mong các bạn có cơ hội tham gia. Mấy bạn ở đây cũng biết cái phong cách rồi đó, thì chắc là sẽ cũng giúp được tụi mình một chút để hướng dẫn, động viên các bạn khóa sau hoạt động lớp tích cực hơn. Thì đó là cũng một điều mình thấy là đáng để ưu tiên cho các bạn vô lớp sau, nhưng mà ráng lên ha.
Dạ, thưa các thầy, tiếp theo ý kiến của thầy Minh Đỗ thì em có một cái đề nghị thế này có được không ạ? Tức là cái lớp này thì cũng gần cái buổi cuối rồi, thì cũng chia tay các thầy các bạn thì cũng rất là bình dị. Tuy nhiên là như thầy Minh Đỗ có nói thì khả năng mà để theo cái lớp sau thì cũng không phải tất cả các bạn trong nhóm là đều có thể vào được. Thì cá nhân em có một nguyện vọng đối với thầy và ban tổ chức là nếu như không được vào cái lớp ấy thì thầy có thể share những cái bài ghi lại cho cái nhóm 101 này được không? Còn em có thể là qua đó thì cũng có thể nghe để cải thiện được phần nào, vì cũng nghe lại dòng của các thầy thì sẽ thấy là dễ tiếp thu và lại có cái chút thân thương tình cảm trong này hơn. Cảm ơn thầy.
Vâng, em thấy ý kiến của anh Thọ cũng rất là hay đấy ạ thầy ạ. Nếu như mà có thể được thì cho bọn em được dự thính vào cái lớp đấy thì tốt nhất, còn nếu như không được thì thầy share lại cái bài của các thầy vào cái nhóm 101 đấy thì bọn em được nghe lại thầy ạ. Thì quá là hay ạ.
Rồi thì sẽ cố gắng, cái này chắc là phải nhờ thầy Dinh-Van.
Vâng. Bọn em thì là rất muốn học, rất ham học, nhưng mà kiểu như trình độ nói thật với thầy là nó cũng còn bị giới hạn đấy, nên là ở cái khả năng, cái level của bọn em nó chưa đạt đến đấy thì thầy cứ ưu tiên cho bọn em để bọn em có cơ hội được học thì là nó vỡ vạc ra dần thầy ạ.
Cũng đang tính đó, thì biết là các anh chị tới buổi này là chắc chắn là có quyết tâm cao, mà thực sự người ta tới tính đó, cái cơ hội thành công trong đời thì cái quyết tâm nó cao nhất, cái yếu tố quan trọng nhất. Thì hy vọng là cũng sẽ tạo được điều kiện cho các anh chị tiếp tục trên con đường rất là dài này, nhưng mà có các anh chị đây có cái tố chất rất quan trọng nhất là cái quyết tâm, đó là quan trọng nhất.
Vâng, cái này tôi muốn chia sẻ chung với bác sĩ Minh và bác sĩ Định là một trong những cái bài học mà chúng tôi nói, bài học cũng nó cụ thể hơn là những gì mà chúng ta học được trong những cái khóa trước đó, là cái việc lựa chọn học viên rất là quan trọng. Thì trong khoa học nó có cái câu là garbage in garbage out, các quý vị nghe câu đó là biết là chúng ta lựa được những cái học viên mà thật sự có tâm huyết thì cái kết quả thường nó sẽ tốt hơn. Tôi muốn tiếp lời bác sĩ Minh ở đây là quý vị ở đây là rất là có tâm và có thể nói là một trong yếu tố cực kỳ quan trọng để thành công. khi mà tôi hướng dẫn bác sĩ nội trú hoặc là nghiên cứu sinh đó, một trong những cái điểm đầu tiên mà tôi đồng ý ở những cái em này là cái quyết tâm. Thì thực sự cái đó là cái điểm rất là quan trọng, và hy vọng là chúng ta sẽ có, cho dù được không được, chúng tôi nghĩ là sẽ có thể cho quý vị những cái bài giảng để quý vị có thể nghe thêm. Tại vì tôi nghĩ cái phần 2 nó sẽ khá thú vị ở điểm là phần 2 chúng ta sẽ có nhiều bác sĩ chuyên khoa hơn, và sẽ có những cái tranh luận rất là sâu mà cũng rất là thú vị giữa những bác sĩ với nhau. Tôi muốn quý vị nghe, và một trong những cái gọi là có thể là tôi đang suy nghĩ bây giờ là tôi mang bác sĩ nội trú của tôi vào luôn, có nghĩa là tôi muốn chính bác sĩ nội trú của Mỹ nói chuyện cho quý vị sẽ thấy nó khác hơn. Tôi nghĩ rằng những cái đó nó sẽ khiến cho chúng ta có những cái thú vị, những cái quan điểm, những cái cách nhìn nó khác nhau. Nhưng mà tôi rất là cảm ơn những cái ý định của quý vị là muốn tiếp tục cái lớp 201 này. Hy vọng là chúng ta sẽ còn tiếp tục gặp nhau nữa.
Bây giờ mình xin nói một chút xíu với mấy em là tại vì đây là cái buổi cuối cùng, tuần sau là mấy em thi rồi, cũng chưa chắc là chúng ta có thể gặp hay không gặp thì cũng chưa tính, tại chúng tôi còn phải bàn với lại bên trung tâm Hoa Kỳ của đại sứ quán nữa. Nhưng mà nói chung kể như là buổi này buổi cuối cùng thì ngày hôm nay mấy em có cái gì nói á, thì nói hết, thì cái đó không cho mấy em, nhưng mà cho những cái lớp sau, đúng không? Nhưng mà ở đây tôi cũng xin nhắc với em đó, đây là cái lớp cơ bản, là cái lớp về thuật ngữ. Thì mấy em, nếu mà mấy em học y khoa mấy em biết rồi, vô học á, năm đầu á, là cái năm mà nhức đầu nhất. Thí dụ như là cơ thể học, tức là giải phẫu học á, rồi mấy cái sinh lý học, tức là những thứ mới, ký sinh, vi sinh. Thì cái này cũng tương tự vậy á, nhớ phải nhiều, không suy luận nhiều. Nhưng mà bữa nay Dr Wynn đã cho mấy em thấy cái không khí của cái lớp học tới. Lớp học tới đó là tranh luận và nói chuyện với nhau trên những cái đề tài. Nó cái không khí học đó nó hoàn toàn khác hẳn, mà vì nó cái kiểu dạy, kiểu học khác hẳn, do đó chúng tôi cũng phải đòi hỏi những cái kỹ năng cũng tương đối để thích ứng. Chứ mà có những em, thật sự mà nói, có những em ở đây sẽ được vào. Thì tôi từ đầu tới đuôi, tôi kỳ nào tôi cũng theo dõi mấy em, thì tôi cũng biết, cũng coi đầu, coi tay, coi chân của mấy em rồi ha. Thì có một số em sẽ được vào và một số em sẽ không được vào, tại vì mấy em mà không đủ để mà giữ cái lớp đó sẽ kéo toàn bộ cái lớp học xuống, mà chúng tôi không thích như vậy. Chúng tôi muốn là cái tiến độ của lớp học nó có hiệu quả. Do đó thì bữa nay thì cũng có thể nói là xin lỗi trước với một số em, là không thể nào chúng tôi có thể nhận mấy em được, nhưng mà chắc chắn trong lớp này có một số em sẽ đi tiếp tục vào cái lớp học kỳ tới. Rồi còn có gì nữa không? Wynn với Minh còn gì nữa không? Còn không thì chúng ta chấm dứt ở đây ha. Nhưng mà giờ có em nào nói những ý kiến gì nữa không? Ngoài những ý kiến mà thứ nhất là nhiều quá, chúng tôi cũng đồng ý rất là nhiều. Học khó nhớ phải không? Rồi không kiểm tra được đầy đủ cũng có.
Em chào thầy ạ. Chào thầy ạ. Chào mọi người. Thì hôm nay cũng là buổi cuối rồi, thì thực ra thì em cũng có một chút ý kiến như này. Vì đây là lớp cơ bản và hầu hết thành phần thì cũng khá là nhiều đối tượng, từ các anh chị bên dược, xong đến các bạn sinh viên, rồi đến các anh chị trong các chuyên khoa. Thế nên mỗi đối tượng chúng ta lại có cách tiếp cận khác nhau về tiếng Anh chuyên ngành, cũng như cái giai đoạn học của em từ thời sinh viên đến bây giờ nó cũng có sự khác biệt về tiếng Anh chuyên ngành. Thế thì em nghĩ là về khóa này thì không có gì để bàn cãi rồi, tại vì các thầy đã đưa cho chúng em cái tổng quan nhất về tiếng Anh chuyên ngành cũng như cái cơ bản nhất. Còn việc mà áp dụng như thế nào nó sẽ tùy thuộc vào từng đối tượng, chứ không phải ai cũng sẽ áp dụng như cách giống nhau cả. Như đối với bản thân em thì em cũng sẽ chỉ áp dụng những vấn đề hay những từ chuyên ngành mà em gặp trong chuyên ngành của em là nhiều thôi. Còn những cái từ khác thì khi nào gặp thì em sẽ lại tra ra, giống như vậy. Để mà đòi hỏi mà bảo biết hết thì cũng rất là khó, như bản thân em cũng không thể nhớ được. Thì thực ra thì em có một ý tưởng là nếu như mà bạn nào muốn về việc thực hành tiếng Anh chuyên ngành thì bạn ấy cũng có thể là practice by yourself. Xong đó thì bạn ấy có thể post cái video đấy lên Facebook và nhờ các thầy trong nhóm là bình luận xem là nói như thế này có ổn chưa, hay là về cách sử dụng như vậy thì có ổn chưa. Như vậy là em cũng rất mong muốn là được nhờ các thầy, nếu như mà có cơ hội ai nhiệt tình thì cũng có thể hướng dẫn như vậy, tại vì practice is make perfect. Em nghĩ vậy ạ. Hết ý kiến ạ.
Cảm ơn em.
Bạn thì mình cũng mong muốn thêm nhiều người có tinh thần như vậy đó, không chỉ là chờ đợi mấy hướng dẫn viên phê bình đâu, mà thực ra trong lớp này thì người có level cao hơn cũng có, người có level thấp hơn cũng có, thì hỗ trợ nhau thì cũng là một cái ý hay. Có thể mình không có thể biết hết mọi chuyện, nhưng mà ví dụ bạn nào đọc từ phát âm nhấn sai chẳng hạn thì mình có thể giúp chỉ ra cho bạn rồi, thì đó thì như vậy thì mình cùng tiến bộ hơn, cũng đỡ cho mấy người hướng dẫn phải đi hướng dẫn tất cả mọi người thì cũng mệt hơn. Thì chung sức coi như là crowdsource, mình dùng năng lực của cộng đồng để mình hỗ trợ lẫn nhau, thì cái đó là cái ý mình mong muốn là các bạn từ từ giúp đỡ lẫn nhau, thì cái đó là cách tốt. Còn cả mấy người bây giờ cũng như là trong gia đình lớn chút xíu rồi, đúng không? Gia đình lớn con cháu cũng 50 mấy người rồi, thì coi như là gia đình nhỏ nhỏ gì đó, rồi cứ thực tập, rồi cứ post lên, rồi tag bạn Nga đổ vô nè, bạn Nga đổ giỏi nè. nói coi giùm tôi
Không. Ngại em thế. Không, em không dám nhận em giỏi đâu ạ.
Giỏi hơn bạn chưa giỏi, từ từ phải giúp bạn mới giỏi lên được chứ. Rồi xong rồi nói
nhưng mà
bạn
thực
nói giúp
tình như
bạn
thế này tôi nói mấy em tôi mở cái khóa ngoại khóa cho mấy em là để luyện nói. Một số em nói không có tốt thì tôi có một cái rất là chưng hửng đó, của một số em nó phát âm khá tốt rồi mà vẫn đăng ký học tôi, trong khi đó một số em phát âm rất là tệ và không thấy xuất hiện. Tôi nói thật sự như vậy á, đúng ra những người đó phải tự thấy là bản thân mình là chưa phát âm tốt thì phải học thêm, nhưng mà như vậy thì thôi, thì cái đó là tự nguyện của mỗi người ha. Nhưng mà nói chung á, đó là nói trở lại đó là cái motivation của mình là quan trọng nhất, chứ không có ai mà thúc được mấy em được hết.
Ok, như vậy thì cảm ơn tất cả các anh chị. Hy vọng là chúng ta sẽ có dịp gặp nhau ngoài đời. Tôi biết là cái Zoom này nó ảo, nhưng mà hy vọng là tôi vẫn thỉnh thoảng cũng thấy vui khi thấy cái người mình đã từng trao đổi hoặc là học viên của mình gặp nhau ngoài đời. Hy vọng lúc đó quý anh chị có thể nói tiếng Anh với tôi cũng được, không sao hết. Lúc đó đừng có đem tôi đi mẫu C là được rồi. Nhưng bữa nay
tháng 7 này tôi báo là Win chính về Việt Nam mà.
Yes. Yes, kế hoạch là như vậy, là tại vì tôi có ra mắt cuốn sách thứ 5 của mình. Nếu mà không có gì thay đổi thì ở Sài Gòn sẽ gặp quý vị. Nhưng mà gần tới đó thì có lẽ trên trang web chính thức team của Dr Wynn Tran sẽ thông báo cho mọi người biết. Hiện tại thì bây giờ cái lịch vẫn là như vậy, nhưng mà có nhiều thứ chưa có, nhưng có lẽ là như vậy. Nếu quý vị nào muốn đọc sách thì có thể đến gặp.
Thầy, mình cũng có mở cái khóa quản lý thời gian.
Tôi thấy là cái này là chắc là tôi sẽ mà chia sẻ cái đó với những anh chị nào quan tâm, tại vì tôi nghĩ là quan trọng lắm. Với cá nhân tôi chia sẻ tí xíu cho quý vị thấy là tôi đi chơi không à. Cuối tuần tôi rất là đi chơi nhiều. Người ta có hỏi hoài sao ông bác sĩ này có nhiều thời gian quá. Thật sự tôi đâu có nhiều thời gian đâu, tôi cũng giống như bác sĩ Đinh hay bác sĩ Đinh Minh thôi, nhưng mà đơn giản là cái lựa chọn của tôi khác với nhiều người. Có những cái tôi nghĩ là quan trọng hơn và tôi làm những cái đó xong, ví dụ là như vậy. Thì trong cái khóa đó tôi sẽ chia sẻ quý vị những cái rất là thực tế và tôi nghĩ là quý vị có thể áp dụng được trong cuộc sống của mình. Và cái đó là thật sự luôn đó, tôi nghĩ là phải quan trọng lắm trong trường y khoa đó. Mỗi lần tôi dạy đây với trường đại học đây, mấy bạn resident, mấy bạn nào cũng thích hết. Có hai thứ tôi nói là đa số bác sĩ đều được thích nha, là quản lý tiền bạc và quản lý thời gian. Là tại vì bác sĩ không có biết quản lý tiền bạc. Và thứ hai là không biết quản lý thời gian. Cái tiền bạc rất là đơn giản, như là anh chị làm 10.000 mà anh chị xài 9.000, anh chị còn giữ có 1.000. Trong khi anh chị làm 3.000 mà anh chị xài có 500 thôi, anh chị giữ được 2.500. Thì cuối cùng cái số tiền 2.500 đó mới là cái quan trọng, chứ không phải là cái số tiền quan trọng một năm anh chị làm bao nhiêu tiền. Thì cái đó là một trong những cái. Mà thứ hai nữa là cái quan niệm về đầu tư. Có nghĩa là nhiều bạn trẻ hay nói là tôi đợi tôi có tiền tôi mới đầu tư. Cái này là cái sai lầm thứ nhất. Tại vì nếu mà đợi quý vị có tiền tôi thì không biết khi nào quý vị mới có tiền, lâu quá. Trong khi có những cái mà chúng ta hay đầu tư ngay bây giờ, mà cái đầu tư quan trọng nhất mà quý vị quên là quý vị biết cái gì không? Đầu tư kiến thức. Cái đầu tư kiến thức là cái sẽ khiến quý vị đi xa hơn, kiếm tiền nhanh hơn, hiệu quả hơn. Thay vì quý vị đi mua cái nhà cho thuê, tôi nói ví dụ nha, làm như thế này, trong khi quý vị lấy cái số tiền đó để học cái khóa chuyên khoa này, đi trở thành này và thành bác sĩ này, nó sẽ nhanh hơn và nó sẽ kiếm nhiều tiền hơn. Thì những cái bài học của tôi rất là đơn giản như vậy, và đa số là người ta thấy nó thú vị. Thì hy vọng là sẽ có dịp, tôi chưa biết cái lịch như thế nào, nhưng mà chắc sẽ thông báo với mọi người nếu mà lịch nó cụ thể hơn. Nhưng tôi đây là một trong những cái khóa mà Vietnam rất là muốn chia sẻ với quý vị, tại vì tôi tin là ai ở ngoài kia cũng muốn hai thứ là quản lý thời gian với quản lý tiền bạc, đúng không? Bởi vì khi mà mình khá cái này rồi, tự nhiên thấy cuộc đời nó nhẹ nhàng lắm. Tôi thật tôi không dám nói là mình làm tốt, nhưng mà tôi rất là blessed, nhưng mình rất là cảm ơn cuộc sống này. Tôi có một cuộc sống có thể nó rất là thoải mái. Mặc dù ở đây, cuối cùng nha, đừng có nghĩ mình giàu, mình không có giàu, hoặc là mình nghĩ rằng đừng có quá quan trọng tới cái việc tiền bạc, thì tự nhiên mọi thứ nó sẽ dễ lắm. Đó là những cái lời có thể là chia sẻ trong một vài phút về những cái này. Phải nói là nhân cơ hội cảm ơn anh Dinh, cảm ơn mình, nhất là bác sĩ Dinh. Quý vị biết không, khi là làm việc behind the scene, tôi nói thật là cái khóa này là anh Dinh cực kỳ mà stress và lo luôn á, tại vì đây là một khóa rất là lớn. Hồi xưa giờ việc em đi dạy mà dạy nhỏ nhỏ không mà, nhưng cái khóa này là khóa lớn nhất, thành ra phải nói là anh Dinh và anh Minh, rồi thêm dược sĩ Thùy Dương, rồi những cái anh chị bác sĩ khác nữa. Tôi thấy là hình như anh Đinh với anh Minh mỗi người cùng với tôi già đến 5 tuổi. Không biết là có phải tại khóa này không, nhưng mà tôi đoán là vậy. Là nếu mà chúng ta dạy thêm khóa sau nữa, anh em mình già đến 10 tuổi rồi.
Thầy trước dạy thì là già 5 tuổi, nhưng sau khi dạy xong các thầy lại trẻ 5 tuổi thầy ạ.
Ok, rồi tôi xin phép được tạm biệt mọi người nha. Rồi
Em chào các thầy ạ. Vâng, cảm ơn các thầy ạ.
Em cảm ơn các thầy ạ. Chào các thầy ạ.
Vui vẻ ha.
Vâng, em cảm ơn các thầy.